start by introducing our speaker, Dr. Sara Hegab. We're very lucky to have her here to talk to us today. We utilize her expertise quite a bit on the transplant services, but Sara joined us actually having completed her residency as well as her fellowship in pulmonary and critical care medicine here in 2015. She actually served as a chief fellow during that period of time. And in 2017 became an assistant professor at Wayne State University. She's currently the co-director for the Pulmonary Hypertension Program at St. John Providence, but most importantly for us is the associate director for the Pulmonary Hypertension Program here at Henry Ford. Sara's been involved in a number of clinical trials for pulmonary hypertension, is a frequent invited speaker on the subject, and has just completed a book chapter and 2 peer-reviewed articles. So she's really kind of up and coming in the pulmonary hypertension arena, and we're very fortunate to have her here today to talk to us about pulmonary hypertension and solid organ transplantation.
Thank you, Dr. Brown, for that very kind introduction. Thank you for the invitation to speak to you today. I'm very excited to talk to you about pulmonary hypertension, solid organ transplantation. These are my disclosures. None are relevant to today's talk. First, I want to start off by really saying thank you to the institution, to our team. Our pulmonary hypertension program a few years ago earned designation as a comprehensive care center for pulmonary hypertension, and there's only a handful of programs across the country who have earned this designation, and so I think that's something that we should all be really, really proud of. The objectives of today's talk are to talk a little bit about the updates in pathogenesis and definitions of pulmonary hypertension, really outline the differences in hemodynamic phenotypes with particular attention to considerations in liver and kidney transplant, and we'll touch a little bit on lung transplant as well. So what is pulmonary hypertension in general? It's a high-pressure state that exists in the pulmonary vasculature that can be caused by many different conditions. I want you to think about the pulmonary capillary bed here in the middle as the center of this circuit, and anything proximal to this circuit is really the pulmonary artery right here. This is pre-capillary, and anything distal to the pulmonary capillary bed we will talk about as being post-capillary. And so when we talk about pulmonary hypertension, we're really talking about an umbrella term that refers to pulmonary pressure elevation anywhere here, but we really need to make a distinction between whether that pulmonary pressure elevation is happening proximal to the pulmonary capillary bed or whether it's happening distal. And we'll learn a little bit more about why that's important in a little bit. There are different diseases that are implicated in the development of pre-capillary pulmonary hypertension, meaning this in the pulmonary arterial circulation. So things like pulmonary arterial hypertension, congenital heart disease, parenchymal lung disease, pulmonary embolism, and PA sarcoma. As we move a little further down into the pulmonary capillary bed, pulmonary capillary hemangiomatosis, which is a rare condition, can cause pulmonary pressure elevations here. And then we move to the post-capillary component. And really the post-capillary component we think about as the left heart, the pulmonary veins and the left heart. And so in the pulmonary venous compartment, we can have pulmonary vein compression or pulmonary veno-occlusive disease, which is a rare condition that falls under group 1 pulmonary hypertension, but really behaves more similarly to post-capillary PH or PH due to left heart disease. As we continue further down, any pathology in the left atrium can cause elevations in pulmonary pressure, so things like atrial myxomas, atrial arrhythmias, or really any condition that can cause non-compliance of the left atrium. In the left ventricle, valvular disease such as mitral disease, myocardial disease, and we know obesity contributes to the diastolic dysfunction that can occur here. And even if we move further distally, aortic disease or systemic hypertension and CKD can also lead to post-capillary pressure elevation. And so ultimately, the symptoms that a patient will present with will vary depending on whether their pulmonary pressure elevation is due to a pre-capillary etiology or a post-capillary etiology. And the treatment will vary vastly between these two categories. And deciding on which treatment is appropriate will depend on accurately diagnosing the culprit lesion. So let's talk a little bit more about precapillary pH. So normally the right ventricle will receive kind of deoxygenated blood from the body and pump it into the pulmonary arterial circulation, which you see in blue here. Normally this is a low pressure system, and so the right ventricle does not have to, under normal circumstances, deal with a high afterload. If there's constriction of the pulmonary arteries or narrowing of the pulmonary arteries that occurs, as we see happens in pulmonary arterial hypertension, that increases the afterload which the RV has to pump against. The RV is a small muscle that is not designed to do that, and the way that it will initially try to compensate for this, it will dilate. And eventually, right heart failure is what these patients suffer from, and eventually will die from right ventricular failure as a result of this pulmonary pressure elevation here. So we think of the right ventricle as an innocent bystander to what's happening in the pulmonary circulation. In postcapillary pH, it's a little bit different. So we talked about the etiologies being either in the pulmonary vein, the left atrium, or the left ventricle. The left ventricle, by design, is a much stronger, larger muscle, and so will eventually compensate by hypertrophying, a different phenomenon than what you'll see on the right side. Eventually, the pressures will increase, partly in part due to this hypertrophy that occurs. And what you see with postcapillary pH is really more of a backflow phenomenon. So you see backflow of pressure from the left side into the pulmonary circulation, and eventually that affects the right side. So it's not to say that you can't get right ventricular failure from a left heart etiology. That biventricular failure, though, originates due to the problem here and not so much in the pulmonary arterial circulation. Left heart disease is by far still the most common cause of pulmonary hypertension. So this was a large study out of Australia that showed that knowing what the etiology of pulmonary hypertension was for patients referred for echo, about 80% of those patients had left heart disease, with lung disease being a distant second at around 10%. And what you'll see is that PAH and CTEPH represent a very, very small minority of patients who have pulmonary hypertension, which makes sense. These are two very rare conditions, but important to still think about and recognize because they are so under-recognized and as such undertreated. You may have seen the classification of pulmonary hypertension previously in this large, very busy table that divides pulmonary hypertension into 5 different groups. And what's nice about this schematic is that it divides those groups further into those that we have defined treatments for, and those where treatments are less clear. So we have group 1 pulmonary hypertension here, and group 4, which is chronic thromboembolic pulmonary hypertension. We have very clearly defined treatments for these patients. These patients are either candidates for pulmonary vasodilator therapy if they fall into the group 1 category, or if they have CTEPH, they potentially have the only curable form of pulmonary hypertension with surgery. And so this is a group that we pay very close attention to, and in our clinic we see a lot of these patients and really try and find out of the vast majority of patients who have non-group 1 and non-group 4 disease, we're really trying to pick out these patients. Then you have group 2 pulmonary hypertension, which represents the most common cause for PH, so left heart disease. Group 3, which is due to lung disease and sleep-disordered breathing. And then we have group 5 disease, which is a miscellaneous hodgepodge of diseases that don't quite fit neatly into any of the other categories. So every 5 years when the World Symposium for Pulmonary Hypertension meets, they take another look at these group 5 diseases and see has there been any research or literature published that would suggest that these patients should fall into, or these diseases should fall into any of the other groups, and then reclassification can occur. What I think is really important to talk about is that for the group 1 diseases, if you look at the causes, they all seem very heterogeneous. So we have idiopathic IPAH, which is the diagnosis of exclusion. We have drug-induced pulmonary hypertension, connective tissue disease, portal pulmonary, congenital heart disease. And so these seem to be very unrelated etiologies for pulmonary hypertension, yet we group them all in the same category. The reason that happens is because the vascular remodeling that these patients have in group 1 is very similar. And so our understanding of how this remodeling happens is evolving. We know that sustained vasoconstriction in the pulmonary vasculature that's mediated or driven by derangements or dysregulation in endothelial mediators like nitric oxide, prostaglandin I2 that are deficient in these patients, or an excess of endothelin is a strong or is a well-recognized driver of disease. But what's also interesting is we're learning that these patients have excess proliferative potential leading to cellular accumulation. So they have dysregulated apoptosis, and so this is very similar to what you see in malignancy. And so a lot of the research is now shifting into looking at those pathways. What's also evolving is our understanding of the role of inflammation in driving this disease process. And so many of you, whether you do lung, kidney, or liver transplantation, see lots of patients who have autoimmune conditions. And so inflammation is a large driver of this vascular remodeling that we see happen in pulmonary arterial hypertension. What the group 1 diseases all have in common is that if you take their pulmonary arterioles and you look at them under the microscope, they will universally look like this. And so at the top arrow, you see a pulmonary arteriole. You see there is a very narrowed lumen, thickening of the smooth muscle wall and the intima. And more importantly, you see this pathognomonic lesion called a plexiform lesion next to this bottom arrowhead. And so this is pathognomonic for PAH. And so regardless of what the etiology of group 1 disease that these patients have in the group 1 category, they all look like this histopathologically. This means that they tend to respond to treatment in a very predictable way to pulmonary vasodilator therapy and are candidates for pulmonary vasodilator therapy, which is why they fall into that group. Ultimately, what we worry about in pulmonary hypertension is not the PA pressure. I know we all talk about the PA pressure and what the PA pressure is on the echo. Ultimately, the PA pressure is a surrogate for pulmonary vascular resistance. We can't measure PVR non-invasively, so we use the PA pressure as a non-invasive surrogate. As PVR rises, PA pressure will rise proportionally. And at first, in a healthy heart, you'll have a cardiac output that is maintained because you have a right ventricle that is able to compensate against this higher afterload. As PVR increases further, you'll see a further rise in pulmonary arterial pressure, and at some point you'll reach the cardiac output, or the right ventricle will begin to decompensate because it can no longer tolerate pumping against this higher afterload, and you start to see a drop in cardiac output. That drop in cardiac output, when it occurs, it occurs at what we call the symptom threshold. So it's at this point that patients may start to develop exertional dyspnea. They may start to get a little bit of lower extremity edema. PVR will continue to rise untreated, and so will PA pressure, with a proportional decrease in the cardiac output. At some point, though, you will reach kind of this, what we call a cliff here, where PVR continues to rise. The RV has decompensated so much, the cardiac output is so low that the right ventricle cannot even squeeze hard enough to generate or mount a high enough PA pressure. So you actually see your PA pressure start to fall. And so seeing a PA pressure fall on the echo in someone who is clearly clinically getting worse is not a good thing. So in fellow clinic, we'll have a fellow say, I don't know why they're feeling worse, the PA pressure is actually better. It's not. They're probably on this part of the curve. And so again, it's thinking about PA pressure as a surrogate for PVR, and how the PVR is impacting the right ventricle is a big part of what we're looking at. To further demonstrate this, you can see the histopathologic changes that are occurring in the pulmonary vasculature and its association with what's happening with the right ventricle. And so you can see that as we move from a healthy pulmonary arteriole, where you have a normal looking RV that's smaller than your left ventricle, which is what it should look like, to you're moving to these more narrowed vessels, almost completely obliterated here. You can see the right ventricle begin to dilate. There's flattening of the interventricular septum. As things progress, you get ballooning of the right ventricle, and you get septal shifting into the left ventricle. So you actually start to see the left ventricular lumen almost become obliterated and overtaken by how large this RV gets. And so this is what you'll see in very end-stage disease. And really what we're trying to do is capture patients as early as possible in this process and start them on therapy in order to prevent progression to that point. Why is this important? We know that PH of all causes, regardless of group, leads to ventilatory inefficiency and right ventricular failure, exercise intolerance, and ultimately it's a deadly disease. There are new definitions that I think are important for everyone to be aware of. We used to define pulmonary hypertension as a mean PA pressure greater than or equal to 25. That has changed as of the Sixth World Symposium about a year and a half ago. And so the new definition is a mean PA pressure greater than or equal to 20. That's our umbrella term of pulmonary hypertension. In order to call it PAH, meaning that this pressure elevation is due to disease within the pulmonary arterial system, so that pre-capillary disease that we talked about initially, what we add to the definition is we say it's a mean PA greater than or equal to 25 plus normal left-sided filling pressures, so a wedge or LVEDP less than 15. And PVR was added many years ago as part of the definition in order to mandate that this be an invasive hemodynamic diagnosis done via right heart cath. You can't make this diagnosis just based on echo. So we talked about precapillary pH, so that's one of our phenotypes. Isolated post-capillary pH is that other side of that initial graph that I showed you. So it's a mean PA pressure greater than 20 with a high wedge, because that means that your pulmonary you have elevated pulmonary venous pressures, but your PVR is still low. So this is your heart failure patient. This is your standard heart failure patient that probably just needs afterload reduction and diuresis. And that's why we have group 2 in this category. The trickier phenotype is patients who have combined pre and post capillary pH. So what we're saying in this group is that they have a mean PA greater than 20, they have a wedge greater than 15, but their pulmonary vascular resistance is also elevated. And so it's much more challenging to manage these patients, which I'll show you why in a second. So on the left here, you have a patient with pulmonary arterial hypertension. So that typical echo that I showed you, initially that right ventricle that's overtaking the left side, you have a very dilated right atrium. If we cath this patient, we will find that they have very elevated pulmonary arterial pressures, but they have a normal wedge pressure. Okay, so this is your standard PAH patient. Then you have pulmonary venous hypertension. So this is your heart failure patient. You can see the problem here is not the right side. The left side is the side that's dilated. You have a dilated left atrium. And if you cath this patient, while their pulmonary pressures are elevated, the wedge pressure is elevated. So this wedge was around 35 in this graph. And so this pulmonary pressure elevation is entirely attributable to left heart disease. Another thing that is important to note, in most patients, in non-pulmonary arterial hypertension patients, if you have a PA catheter in the ICU, which many of your patients post-operatively, pre and post-operatively will have PA catheters, we can typically use our PA diastolic as a surrogate for our wedge pressure, because normally they are within 4 points of each other. So we don't always get wedge pressures, particularly in SICU and in the CICU. That is not true of PAH patients, because you can see there's a large gradient between your PA diastolic and your wedge pressure. So you cannot use your PA diastolic as a surrogate for your wedge pressure. And that brings us to this patient who has combined pre and post pulmonary hypertension. You can see that their pulmonary arterial pressures are elevated, as is their wedge pressure. But their PA diastolic, which is down here, and their wedge are not superimposed together the way that you see in the left heart failure patient, suggesting that yes, this pulmonary pressure elevation is in part due to left heart failure because the wedge is elevated, but there's something above and beyond happening within the pulmonary vasculature that is also contributing to this pressure elevation. So this is the patient that we refer to as having combined pre and post pulmonary hypertension. What you can see here, these were explanted lungs from patients who underwent heart-lung transplant. We know that they had left heart failure. And what you can see is that as that gradient that I showed you in that middle graph widened, meaning that the pulmonary pressures were higher and it seemed like there was more precapillary vasculopathy that was happening even though these patients had known left heart failure, you can see that their vessels started to narrow and obliterate and become very similar to group 1 IPAH patients. And so what we don't know yet is how best to manage these patients. We know that they're a different phenotype, but but I'll show you in a second why managing them is a little challenging. So ultimately, when a patient comes to pulmonary hypertension clinic, what we're trying to decide is what group they fall into, because that will dictate their management. We have a series of pivotal tests that we do on all patients who come to the clinic. And based on what these pivotal tests are, we will decide whether contingent tests. So if somebody has abnormal pulmonary function testing, then we may need further imaging of their chest in order to investigate whether there's a group 3 component there. And so even if someone comes to us with end-stage liver disease and we suspect that this is portal pulmonary hypertension, that's a diagnosis of exclusion, and so we still need to run through the entire workup and make sure that there's no other contributor to their pulmonary hypertension. So we'll shift to a case. All the cases are real patients that we've seen in this hospital. So this is a 58-year-old male who had HCV complicated by hepatocellular carcinoma, undergoing liver transplant evaluation. He presented with progressive dyspnea and lower extremity edema for 6 months, dizziness, lightheadedness, and pre-syncope with stairs. And he had a 2D echo that showed a preserved left ventricular ejection fraction of 72%, grade 1 diastolic dysfunction, and notably his PA pressure was 63 with a severely enlarged RV, severely reduced RV function, and flattening of the interventricular septum. This patient went on to right heart cath, and what we can see here is that he had a mean PA pressure of 40 with a wedge pressure of 17. And an elevated PVR of 4.2 Wood units or 336 dynes. And so the question is, should this patient go on to transplant or not? And we'll talk about what happened in him in a second. So what is the pathophysiology of portal pulmonary hypertension? Patients with portal hypertension will develop high output states, and that high output state leads to shear stress just because of the high flow that's going through these vessels that are not used to seeing such high flow. There's stress that's placed on the pulmonary vasculature that leads to endothelial dysfunction and vascular remodeling. And we also believe that there's vasoactive substances that bypass the liver through portosystemic collaterals, and they end up reaching the pulmonary circulation, resulting in vasoconstriction. There's some literature to suggest that there are some patients who are genetically predisposed to the development of portal pulmonary hypertension compared to others. Why is it such a problem, and why do we look for it so closely? 10 to 21% of patients with end-stage liver disease will have an RVSP on echo of 30 to 50, and they're often asymptomatic. We know that about 15% of patients referred for liver transplant will have portal pulmonary on right heart cath, and we also know that mortality is significantly increased if the mean PA pressure is greater than 35. Portal pulmonary falls into that group 1 category that we talked about, and from the REVEAL registry, which is a US registry of group 1 patients, you can see portal pulmonary is in this orange line here. And of all the etiologies of group 1, so here they looked at congenital heart disease, who did the best, portal pulmonary portends the worst survival in all of group 1. So within group 1, not all etiologies are created equal. There are various hemodynamic profiles in patients who have portal hypertension. They can either have normal hemodynamics, they can have PAH, which we talked about, and that's that they get vasculopathy that we described and looked at earlier with a normal, or if advanced, reduced cardiac output, but importantly, normal left-sided filling pressures. We know that these patients can have a high flow state, and so they may have elevated pressures on right heart cath, but we will see that their PVR is normal. And these patients often have other comorbidities that predispose them to have all the other things that patients without liver disease have, namely cardiac disease. And so they may have pulmonary venous hypertension. So their PA pressure elevation is due to increases in left-sided filling pressures. So let's take a closer look at this. If we cath a patient who has a high flow state, what we will see is that they will have an elevated mean PA pressure. Their wedge could be normal or on the lower side. Cardiac output will be increased, but what you'll see is their PVR is normal or low, and typically low because often the cardiac output is high. If we look at the pulmonary venous hypertension patient, this is someone who has excess volume on board, and so we will still see an elevation in mean PA pressure, but you'll see that the wedge pressure is dramatically increased. And then the portopulmonary patient, this patient will have substantially increased mean PA pressure compared to the other two. Their PVR will be very high. At first, their cardiac output will be normal until it falls from RV failure, and their wedge pressure should be normal. And so if we look at some examples of these patients, the main distinguishing point between in high flow will be this high output state that will be associated with a low PVR. In excess volume, you'll have an elevated wedge pressure. But in the portopulmonary patient here, you can see the PVR is substantially increased compared to the other two groups. So phenotyping these patients is very, very important prior to a decision about whether they can safely undergo liver transplantation. So what do we worry about during liver transplant? Why are we looking for this RV dysfunction and high PVR with a fine-tooth comb? We know that there are changes, hemodynamic changes that happen with reperfusion of the graft. There is significant increase in cardiac output as well as PVR and pulmonary pressures. And if you have an RV that's deconditioned or already starting to fail, it will not tolerate those hemodynamic changes. And depending on how high the PA pressures are, we have various cutoffs, but mortality is extremely high in patients who have poor RV function due to high PVR intraoperatively. And so in order to try and ensure a successful transplant for the patient, but also out of respect for the graft and making sure that it's going to someone who will be able to tolerate surgery, I think is why we look for this so closely. The most data that we have in the liver transplant literature comes from Mayo Clinic. Krauka is one of the international experts on portopulmonary hypertension. And what they found from their 10-year experience was that if a patient had a mean PA pressure greater than 35, they had a 48% intra or perioperative mortality, usually within 30 days is what they were describing. And that also was true for an elevated PVR greater than 250, 55% mortality. This is where we get our cutoffs from. So if in their series, their 10-year experience, when you had mean PA pressures between 35 to 50, that was associated with a 50% mortality, and greater than 50 was 100% mortality. The question is, do we do right heart caths on every single patient who is undergoing an evaluation for liver transplant? And the initial data that we got from them, from Mayo Clinic, was they looked at patients who had an RVSP of greater than 50, and they did right heart caths on them. And what you'll see, these were patients who, on right heart cath, ended up having a low PVR. And so they weren't a small number of patients. And so basically what he's saying is that echo alone is not going to be what can discriminate your cutoffs. And so right heart cath for RVSPs greater than 50 are really what are recommended. And so the intraoperative guidelines for portopulmonary that come from Mayo are that if a patient has a mean less than 35, we can proceed with liver transplant. Their series had 0% mortality. We talked about the 50% mortality associated with PA pressures of 35 to 50 and 100% mortality for those above 50 where it's recommended to cancel the liver transplant. So these patients all get hemodynamic assessment before a decision is made to proceed or not. What about in patients who didn't get liver transplant? So let's say that for whatever reason they weren't eligible for a transplant or the transplant was canceled. Is there a difference between those who are treated for their portopulmonary hypertension and those who are not? We know that those who received vasodilator therapy for PH ended up having better survival than those that did not. But the best survival by far are those who received PH therapy for portopulmonary and a liver transplant, compared to those who received therapy alone, and obviously those two groups did better than no therapy at all. So the goal in portopulmonary hypertension is not to say that a patient can't get a liver transplant, it's to improve treat them to improve their hemodynamics down to these thresholds. So a mean PA less than 35 with a PVR less than 240 in order to make it safe for them to move forward with transplantation. We had published in 2013, so this was Dr. Oddish had published a 10-year Henry Ford experience, and we actually had very good outcomes compared to national data. So in our portal pulmonary population, we lowered the threshold for moving forward with right heart cath from, at the time, what was recognized to be the recommendation of 50. We lowered our threshold to 40 in order to increase our sensitivity for capturing portal pulmonary hypertension. And what we found that was, compared to the REVEAL registry, so then the national US registry, we had more aggressive prostacyclin use. 67% of our portal pulmonary patients were on prostacyclin compared to 31 nationally. And our 5-year survival when compared to REVEAL was 71% versus 40%. When we compare to the to French data, who had better survival than the US at the time, we still had much better survival than the French despite having sicker patients. So many of their patients had a better Child-Pugh score. So overall, what are the recommendations for portal pulmonary hypertension? We should exclude portal pulmonary in all liver transplant candidates by routine echo. So everybody needs an echo as part of their screening workup. And for RVSP greater than or equal to 45, right heart cath is indicated. We've again lowered our threshold to 40, and so we've asked that they be referred. If you see a PA pressure of 40 on the echo, send them to PH clinic, and we can help sort out timing of right heart cath and when that should be done. Potential recipients of portal pulmonary with portal pulmonary hypertension should be evaluated in a dedicated pulmonary hypertension center that is able to treat these patients with vasodilator therapy. And liver transplantation can be offered to potential recipients who respond to medical therapy with a mean PA pressure or achieving a mean PA pressure less than 35 and a PVR less than 240. The data that we have, so these are all of the drugs that we currently have available for treating pulmonary arterial hypertension. And we have very limited data on what can be used in liver patients. So you have to remember the majority of these patients were excluded from all of these drug trials. What we have to go on are small case series that have been published. And so up until recently, it was prostacyclin and ERAs that were most commonly used. Patent 1 looked at riociguat in group 1 pulmonary hypertension, but they allowed the enrollment of patients with portal pulmonary hypertension. And so we had some small subgroup data, 13 patients with portal pulmonary. And what we were able to see was there was an improvement in PVR as well as mean PA pressure in the portal pulmonary group. The first randomized control trial that was dedicated to patients with portal pulmonary hypertension was Portico, that looked at macitentan in this patient population and found that there was a 35% reduction in PVR. So macitentan is an endothelin receptor antagonist. It's been shown to be safe with no hepatic side effects. So there are predecessors in the endothelin receptor antagonist group that did have hepatic side effects, namely bosentan, that's contraindicated for use in liver disease. But the main problem that we found, and what we have found in our population that I think mirrors what was found in the study, is peripheral edema occurs in about a quarter of these patients. I'd say probably more based on what we see. And so anticipating that and managing that with anticipatory kind of diuretic management is important and has been helpful. So what happened to that first patient that we talked about who had portal pulmonary hypertension? He was treated with IV treprostinil. 9 months later, had complete normalization of his echo. So if we see pre and post-treatment values, you'll see his mean, this is his right heart cath data. His mean PA dropped from 40 to 24, and his PVR dropped from 336 to 228. He was successfully transplanted and weaned off prostacyclin within about 6 months. Another question we get asked is how quickly we should wean vasodilator therapy after surgery. It's a very patient-specific decision and depends on a lot of the comorbid conditions that they have. I can tell you the Mayo data suggests that most patients will remain on some form of pulmonary vasodilator for about 6 months post-transplant. That doesn't mean they have to stay on their prostacyclin. We can often de-escalate to oral therapy, but they will usually need something for about 6 months. All right, so moving to case number 2. 60-year-old female with end-stage liver disease secondary to HCV cirrhosis, has a history of hypertension and AFib. 2D echo showed an EF of 59%, grade 2 diastolic dysfunction, severely dilated left atrium, moderately thickened LV wall, a PA pressure of 70, moderately enlarged RV, and moderately reduced RV function with flattening of the interventricular septum. This patient underwent cath, and what we found was that she had elevated right-sided filling pressure, so right atrial pressure of 12, RV EDP of 15. Her mean PA was 40, but she had a wedge of 25 with a very low diastolic gradient that we talked about earlier. And this was in the setting of a high cardiac output of 9.2. So when you calculate this patient's PVR, even though her mean is above 40, her PVR is low. And so this is high output heart failure that is causing this pressure elevation and not pulmonary arterial hypertension. So this is someone that we would say could move forward with a transplant from the pulmonary hypertension perspective. The left heart failure would probably need to be looked at by cardiology, but at least from a PAH standpoint, this patient would be cleared for surgery. Shifting gears a little bit to renal disease. The mechanisms that cause pulmonary hypertension to develop in renal disease are multifactorial. So patients with kidney disease will often have AV fistulas, which put them in a higher output state. They have anemia, they're often fluid overloaded. They have other comorbid conditions, namely left heart disease that develops fairly rapidly after the initiation of dialysis if they didn't have it to start with. And so they can have systolic or diastolic heart failure. Mitral disease is very common, so that leads to post-capillary pressure elevation. And then there are things that cause the pulmonary vascular resistance to increase. So uremic endothelial dysfunction, they can get pulmonary artery calcifications, they have often sleep-disordered breathing, or lung disease such as COPD. So they can develop pulmonary hypertension due to multifactorial causes. This was an interesting study out of Duke that looked at over 12,000 patients that were referred for right heart cath, and then divided them into those that had CKD and those that did not. And what they found was that the most common causes, or the most common phenotypes of pulmonary hypertension in patients with CKD were isolated post-capillary pulmonary hypertension that you can see in the blue line here. So basically left heart failure or volume overload, or combined pre and post that's in the orange. So what we think happens is that patients who have long-standing left heart disease, all that backflow of pressure that's coming into the pulmonary arterial circulation eventually leads to remodeling of the pulmonary vasculature, and they start to develop pre-capillary disease as well. And so combined pre and post is kind of the worst combination you can have in renal disease and portends poorer survival. In 73 dialysis patients that were consecutively referred for unexplained dyspnea, 1 in 10 in this cohort met criteria for PAH. And this was after exclusion of high output state or LV dysfunction. And so I think just raises the importance of thinking about pulmonary arterial hypertension in this patient population, even though we know that they have a lot of other comorbidities that predispose them to have kind of non-group 1 PH. The other thing that I'll mention here is the renal transplant patients that we see often have connective tissue disease. And connective tissue disease, we talked about the role of inflammation in the development of pulmonary hypertension. So they may have what we call group 1 risk factors, even though they now have end-stage renal disease. And so parsing out how much pre-capillary versus post-capillary disease is what we try and help with. We know that having pulmonary hypertension, so these are hazard ratios, and we know that having pulmonary hypertension in end-stage renal disease to not having pulmonary hypertension portends worse morbidity and mortality. And what was really interesting about this study was they looked at PH pre-renal transplant and tracked these patients' survival post-renal transplant to see what happened. And if patients had an RVSP of greater than 50 on their pre-transplant echo, they had worse survival than if they had lower PA pressures. Now, what they didn't do was parse, this was not a hemodynamic study, so that we don't have right heart caths to know what the etiology of the pulmonary hypertension was and whether it was pre-capillary or post-capillary. But regardless, whether it was left heart failure or whether it was pre-capillary PH that was causing this pressure elevation, if you had high pressures on your echo at baseline, those patients did worse. The other thing that they were able to show was that the pulmonary pressures changed over time. So time on dialysis The longer you were on dialysis, the greater a likelihood, so about half of patients who were on dialysis for greater than 2 years had RVSP greater than 50 on their echoes. And so, or I'm sorry, greater than 35. And so that raises kind of our, or could offer insights into which patients we should be thinking about screening for PH. What about graft dysfunction? So we talked about overall mortality without transplant. We talked about mortality with transplant. What about PH in the renal transplant and graft dysfunction? We know it's an independent predictor of early graft dysfunction in this patient population. We also know that it seems to happen more with deceased donor transplants. And so if you have pulmonary hypertension, you were more likely to have early graft dysfunction if you received a deceased donor transplant. And so that may be something to consider or think about when we're thinking about this high-risk patient population. We also know that from a morbidity standpoint, these patients had, because of the early graft dysfunction, had longer hospitalizations. The proposed cutoff for proceeding, so what's challenging about pre-renal transplant patients is we don't have the clear guidelines that we have for liver transplantation, and much of the data is extrapolated from the liver transplant literature. We know that phenotyping is important in this population because as post-capillary and combined pre- and post-capillary pulmonary hypertension are prevalent, and we talked a little bit about the connective tissue disease prevalence in this patient population. So what our practice has been, our threshold's a little bit higher for renal patients because they do tend to have a lot of left heart disease and volume overload contributing to their echo abnormalities. And so 50 is the referral cutoff for the pulmonary hypertension clinic for kidney patients. And then based on how their echo looks and how the rest of their workup looks, we'll make recommendations about, again, timing for right heart cath. All right, and then our last case is, so shifting gears a little bit to lung transplantation. So a 64-year-old female with sarcoid ILD who was on 4 liters of supplemental oxygen presented with progressive exertional dyspnea, dizziness, lightheadedness, and pre-syncope with minimal exertion. And you can see representative cuts of her CT scan here. We see upper lobe predominant fibrotic disease. What you start to see kind of in this section is there's a difference in attenuation of the lung tissue. It's what we call mosaicism. And so mosaicism is either you have air that is preferentially ventilating some areas better than others, or it's perfusion that is preferentially perfusing some areas better than others. So it's either a heterogeneity in ventilation or perfusion. And so in the ILD population, the automatic thing is to think about differences in ventilation, but I think not forgetting that mosaicism can represent variations in perfusion is also very important. What we see here, and it's not a contrasted study, but you can see that the PA is very dilated. It's as big, if not bigger, than the patient's aorta, which clearly is not normal. From a pulmonary function standpoint, her PFTs weren't that bad. Her FVC was about 65% of predicted. No evidence of obstruction, but you can see the DLCO is profoundly reduced, 25% of predicted, despite, even though there's some parenchymal abnormalities, they weren't terrible, and they certainly weren't the worst we'd seen in a lung transplant evaluation patient. Her 2D echo showed a preserved ejection fraction of 67% and grade 1 diastolic dysfunction, but her PA pressure was 77 with a severely enlarged RV and severely reduced RV function, with flattening of the interventricular septum and severe TR. She underwent cath, and you can see her mean PA pressure was 45 with a normal wedge pressure, really low cardiac output and index, giving her a PVR of 11 Wood units. So the question is this group 1 pulmonary hypertension based on these hemodynamics, or is this group 3, meaning is this PAH that's attributable to parenchymal lung disease, in which case there really wouldn't be anything we could offer from a medical management standpoint. PH in general can complicate any ILD, more so in the fibrotic types. We know that in IPF at transplant evaluation, about 35 to 45% of patients will have pulmonary hypertension, and we know that mortality in IPF with PH is substantially higher. There's a complex interplay that leads to pulmonary hypertension and ILD. So you have parenchymal tissue destruction that leads to vascular distortion of the vasculature and VQ mismatching. We have an inflammatory process that's led or mediated by various cytokines. You have microthromboemboli that happen. These patients are hypoxic, so they get hypoxic vasoconstriction. And then we have other comorbidities. So these patients typically tend to be older and have, sleep disordered breathing or heart failure. And so there are many factors that lead to the development of PH in this patient population. As the interstitial process progresses and vascular ablation and vasculopathy progresses due to the destruction of the tissues and the inflammation that we talked about, there is at some point that we reach an inflection point where the progression of the interstitial process may continue linearly, but the progression of their hemodynamic kind of derangements or dysfunction and pulmonary hypertension accelerates. So we're called when the patients are at this point, where their ILD has been stable for several years, but suddenly it's the pulmonary hypertension that's causing them to decompensate and will eventually lead to their death. This is to highlight that while pulmonary hypertension is not, it's this little purple sliver here, is not a common cause of lung transplant or common indication for lung transplant in the US when you look at all of the diseases that we perform lung transplants for, it is associated with all of the other conditions that we do. So COPD, ILD, bronchiectasis, sarcoidosis, all are associated with the development of pulmonary hypertension. So it is common in this patient population. And again, having PH compared to not having PH portends worse prognosis. So if you have COPD patients who have normal pulmonary pressures, the PH patients do worse. And if you break them down further to stratify how bad does the PH have to be, typically if you have a mean PA greater than 40 and you have COPD, you have very, very poor survival. So what we try and do in this patient population is to stratify what criteria they have that favor group 1 versus what criteria they have that favor group 3, because this has huge implications on how we manage these patients. So it's a busy slide, but ultimately what we're saying here is that if someone does not have severe lung disease, meaning FEV1 is greater than 60% of predicted or 70 in the case of ILD, and they have a low DLCO in relation to the amount of obstruction and restriction that they have on imaging, then that suggests that this is a group 1 etiology. But if we have severe impairment in PFTs, we have lots of fibrosis and scarring on their CT, that really does suggest a group 3 etiology. We'll then do a cath, and we will look at their PA pressures and their hemodynamics. If they have really bad lung disease and only mild to moderate pH, that's probably a group 3 patient whose pulmonary hypertension can be entirely attributable to their lung disease. Whereas if they have moderate to severe pH and their PFTs and imaging isn't that bad, that's probably just a group 1 patient who happened to have a little bit of lung disease. So very, very different patients on these sides. A test that we utilize fairly frequently is cardiopulmonary exercise testing. So we're able to elucidate whether a patient's exercise limitation is due to a ventilatory limitation or pump limitation to exercise. And if they have a pump limitation to exercise despite having lung disease, that suggests that maybe they have a predominant hemodynamic profile. The most important thing I want to draw your attention to here is ultimately, if you have a mean PA pressure greater than 35 on cath in the setting of lung disease, what we think, or what we say, is that that is discordant. That degree of pressure elevation is discordant with the amount of lung disease that a patient has. In other words, you can explain up to a mean of 35 with lung disease. Above that is a patient who has disproportionate, or what we used to call out of proportion pulmonary hypertension. And that patient might be a candidate for pulmonary vasodilator therapy. This was a patient who had severe PH pre-lung transplant for ILD, and you can see a very dilated right ventricle, dilated right atrium. The left ventricle is tiny and almost obliterated here. And you can see normalization of this echo after bilateral lung transplant. And so the RV is very resilient and will recover once you improve this PVR or post-transplant, even without pulmonary vasodilator therapy. And so this patient was referred for lung transplant evaluation. So when we had initially seen her, we were concerned that we weren't going to be able to treat her with pulmonary vasodilator therapy. If you think about it, our body's natural compensatory mechanism when we're not ventilating well is to vasoconstrict poorly ventilated areas so that we're shunting blood to normal, healthy lung. And when we give pulmonary vasodilators, they act indiscriminately on the entire vasculature, so we're suddenly removing that compensatory mechanism. So the reason that you might hear us talk about whether we can or can't treat these patients is pulmonary vasodilators can worsen VQ mismatch in somebody who has lung disease. That becomes relevant in the liver and kidney population because sometimes we've talked about, well, they don't have PH now and I don't think they need therapy, but what if something happens down the road postoperatively and they have a little bit of COPD or they have a little bit of lung disease? Is this somebody that will tolerate that or not? So we're looking at all of those things during patient evaluation. This patient, unfortunately, was found to have vulvar cancer as part of her workup and was deemed not a candidate for lung transplant for about 5 years. And so we decided to bite the bullet and start her on IV treprostinil and see how she did for group 1 PAH. And what you'll see here is that she had significant improvement in her PA pressure on echo. She went from a severely dilated RV to mildly dilated. Her septum has normalized. Her fractional area change went from 10 to 48%, and her walk distance improved to 436 meters. She's New York Heart Association functional class 1 now, doing really well, and what we're hopeful for is that she'll now survive long enough for those 5 years to be up to see if she'd be a candidate for lung transplant in the future. PH overall is an independent risk factor for primary graft dysfunction after lung transplant. So we know that PGD is associated with higher mortality and bronchiolitis obliterans. And we think it's due to activation of the innate immune system and increased endothelial permeability and capillary leak after reperfusion. We know that if you have pulmonary hypertension pre-lung transplant, regardless of what your WHO group is, you have a 3-fold increased risk for PGD. And we think that it's probably due to left ventricular dysfunction that happens due to this ventricular interdependence. So again, when the RV overtakes the LV and you have narrowing of this LV and this abnormal diastology, that can lead to the development of pulmonary edema in the postoperative period. And so the management for PGD is ultimately supportive care, low tidal volume ventilation, restrictive fluid strategy. Inhaled NO has been looked at, but it doesn't prevent primary graft dysfunction, but may help improve oxygenation. And ECMO is becoming increasingly used in severe primary graft dysfunction, and in some studies, this was a study out of Germany, that used it preemptively. So they transplanted patients, they put them on ECMO, and the idea is that the left ventricle, for the longest time, due to this high pulmonary vascular resistance, has been underfilled. So it's a deconditioned left ventricle because the RV in these patients has been so dysfunctional for so long. You suddenly give them new lungs, the PVR goes down, the right ventricle has better output, and this poor little LV is overwhelmed with this preload that it's not conditioned to handle. And primary graft dysfunction ensues. And so the idea behind using VA ECMO kind of immediately post-op is to provide hemodynamic support and almost recondition the LV over a few days to be able to tolerate the increased preload that it's receiving. And you can see patients who were received bilateral lung transplant and were on ECMO did better than those who were on routine ventilation. And so in summary, screening for pulmonary hypertension with 2D echo in those being considered for solid organ transplants is essential. It has implications on graft dysfunction and mortality after solid organ transplantation. Phenotyping is crucial to understanding the underlying cause of PH, which will inform candidacy, risk stratification, and management strategy in the perioperative period. When it comes to liver and kidney, referral to pulmonary hypertension specialists if the PA pressure on 2D echo is greater than 40 or there's evidence of RV dysfunction. And ongoing screening for the development of PH with 2D echo every 6 to 12 months for those listed for transplant, because just because they don't currently have PH doesn't mean that in the year that they're waiting, they might not develop pulmonary hypertension. So rescreening is important. When it comes to lung disease, distinguishing between group 1 and 3 PH in those undergoing lung transplant can be challenging and again should be managed at a specialized PH Center. And I'd like to say thank you to our team. So we're very proud of the fact that in the last few years we've become a multidisciplinary team. So we are pulmonary critical care. Jillian Grafton joined us a few years ago, who's advanced heart failure cardiology. More recently, Reem is our nurse practitioner, so she's seeing a lot of patients in clinic as well as on the inpatient side. And so we're happy with the team we've put together, and Trish and Ken are our nurse coordinators who are the glue that keep our team together, and we wouldn't be able to do anything without them, so thank you.
So I think we have time for a couple of questions. Yeah, absolutely.
So thank you very much for the wonderful talk. I think we all go through this battle, it's the liver and kidney side a lot, and knowing the pre and post capillary issues are profound. On the liver side, there's a concern that we've had, and it's anecdotal more than anything else, is that even though they may have high cardiac output, that we're still worried about the systolic right ventricular pressure. Most because they are so vasoplegic on the systemic side, so the pressure may be 70 or 80. But their PA pressures in the 50, 60, 70. And does that low pressure, low SVR impact in a similar way to what systemic hypertension does to the left side, in the sense that it unloads the entire pulmonary circuit, so you may mask pulmonary hypertension instead? Understand that? Because it's like assumption, not a resumption.
Sure.
So if you're always worried about that, the two cases we had way back when, high cardiac output, 10, 11, 12, and they went into right heart failure after reperfusion because the PA pressure was 65, 70.
Right.
And then right systolic pressure was 50. And we're chasing that.
Sure. I think it's hard to comment generally on that. I think looking at what the left ventricular function is at that point, looking at the severity of the RV dysfunction at that point. So if they were high output but had no evidence of RV dysfunction prior to transplant, then I think the likelihood of that happening is less. But you can also develop biventricular failure and still be in a high output state. And I think that's a very different patient than someone who has preserved RV function. So I think what I thought you were going to talk about with the SVR is the other way, is that these patients have a low SVR for a really, really long time, and then suddenly you give them a new liver, their SVR normalizes, and their left ventricle can't tolerate that afterload. And so we've also seen left heart failure develop after in these patients. And so, but I think you're right. I think the complexities of the interplay between SVR and PVR are really hard to manage, and they're hard to predict preoperatively.
It does later. I think he's talking about acute events right at reperfusion.
Yeah. I think it depends on what the echo and the hemodynamics show preoperatively with regards to RV function. So again, somebody who has starting off surgery with a CVP in the teens to 20 and an RV EDP that's elevated and has clearly a dilated RV on echo or TEE preoperatively, they're in a high output state, but their RV is now in severe failure. That's a different patient than someone who has preserved RV function and they just happen to be to have a cardiac output of 9 or 10. So that would be how I would look at it. Mm-hmm.
So, can you comment about the role of the arterial blood gas in stratifying these patients? So it's obviously very important about pulmonary syndrome. If you look at somebody, these two patients with exact same hemodynamics, one has a good gas, one has a bad gas. What is the meaning of that?
So I didn't touch on hepatopulmonary syndrome during this talk, but the blood gas really has a role in stratifying HPS patients more so than in portal pulmonary patients. And so we've traditionally thought of these two processes as not being able to coexist in the same patient because it's almost like seemingly opposite pathophysiology. But we are, I think, also from the Mayo data seeing that you can have a small minority of patients who have HPS and portal pulmonary, but again, that's exceedingly rare.
Well, thank you very much. I
Thank you.
appreciate it.